we will turn it over. Thanks again, Mike, to our colleagues from Children's Hospital for Pediatric Kidney Biopsy Conference.
Thank you very much. I am Robin Reed. I am a pediatric pathologist at Seattle Children's Hospital, and I will be sharing some cases today along with my colleagues. My co-presenters today are going to be, I think I'm sharing the right screen, are going to be three pediatric nephrology fellows at Seattle Children's, Chloe Douglas, Sarah McHugh, and Amber Kazi. And I did not, yeah. Okay, and our first case is going to be presented, the clinical is going to be presented by Dr. Chloe Douglas.
Great. Hi, everyone. I'm Chloe. I'm one of the senior PEDS fellows over at Children's, and these slides were made in conjunction with Shana Menon. And I'll start with this case, which is a 17-year-old female with a history of FSGS, status post-deceased donor kidney transplant in 2020, who presented to an outside hospital in Montana on the spring with 7 days of fever, malaise, and poor PO intake. Prior to presentation, like I said, her end stage was secondary to FSGS and was had a deceased donor in 2020, and she had this novel mutation of unknown pathogenicity come up on her pre-transplant genetic testing, but otherwise no other mutations noted. She had a history of spinal arthropathy, but great adherence, no previous rejection episodes, and her most recent DSA was negative in all channels. Her immunosuppression regimen consisted of TAC, everolimus, and PRED. She had a history of GI upset on MMS, so thus she was on everolimus. So prior to presentation, she actually had her routine transplant screening labs for 4 days prior to that ED visit with a creatinine of 1.2, with her baseline being 0.7 to 0.9. She's noted to have a bicarb of 17, a serum sodium of 131, an H&H that were stable to baseline of 11 and 35, normal white count and normal platelets. And her urine was positive for 1+ protein, moderate leuks, positive for nitrites, 50 to 100 red cells, and 10 to 20 white blood cells. And her urine culture grew out E. coli. Thus, she was started on nitrofurantoin. However, at the local ED evaluation 4 days after those labs, she's noted to be febrile with a temperature of 39, hypotensive with blood pressures 80s over 50s, but otherwise no pertinent findings on her exam. Her labs were notable for continued rise in her creatinine to 1.8, a serum sodium of 131, bicarb of 14, and she continued to have proteinuria with 3+ protein, greater than 100 red cells, and 5 to 10 white cells. A renal ultrasound was obtained locally that was overall unremarkable of her graft. She was given an IV fluid bolus. She started on ceftriaxone for presumed pyelo, and then she was transferred to our hospital for further management. So at our hospital, her creatinine was 1.8 as it was at that last check at the outside ER. Her sodium was 130 and her bicarb was 14. Her H&H had somewhat decreased to 10.5 and 31.3 with a stable white count of 6.2. Her platelets had also decreased to 178. She continued to have proteinuria, hematuria that was microscopic and 5 to 10 white cells. We did repeat the kidney ultrasound in-house, and overall there was no changes in her transplanted kidney. And so I'll let you guys think about what other additional testing that you would consider at this time. If you want, you can put it in your chat, but just to be time sensitive, we'll move on. And so overall, we did send serum BK, CMV, and EBV that continued to depend on hospital day 1. Her DSAs were noted to be negative. And then we did send an admission respiratory viral panel that screens for multiple viruses, and she screened positive for adenovirus. So then on hospital day 2, she continued to have fever, and then she developed clinical concern for hemorrhagic cystitis. So she had new gross hematuria with large blood clots and had dysuria with that initial void. A repeat renal bladder ultrasound had normal Doppler exam, but had now new mild hydronephrosis and urothelial thickening. Then on hospital day 3, her dysuria resolved actually after 1 to 2 voids, and her urine color changed from bright red to amber to then yellow with just large clots. And she continued to have high fevers of 40 degrees Celsius, and her creatinine rose to 2.8. Thus, we held her tacrolimus. And then given concern of perhaps nephritis along with other processes, we opted to pursue a kidney biopsy, and I'll hand it off to Robin.
Thank you. This is a low magnification image of what her kidney biopsy looked like. And what you can see is that we have three renal cores here with a really heterogeneous appearance, where at low magnification, at least, you get a sense that there are areas of better preserved parenchyma, although there's interstitial hemorrhage and inflammation even there. And then there's some areas with very dense inflammation here, and there's some others that I'll show you as well. I'm going to start every kidney biopsy review by showing you a low magnification trichrome image just to get an overview of the renal parenchyma. And in this low magnification trichrome, I think you can appreciate that the sort of predominant picture is one of dense interstitial inflammation that's sort of patchy. There's a bit of tubular atrophy, not too much, a bit of interstitial fibrosis, and maybe some mild diffuse interstitial fibrosis here. But the big picture here is essentially that there's a lot of interstitial inflammation, as well as tubular injury and tubular inflammation, but variable from core to core and from field to field within the core. For the rest of my description, I'm going to focus in on one end of the core, which was involved by this dense inflammation. Excuse me. And this dense interstitial and tubular inflammation and hemorrhage. And looking more closely, you can see that this inflammation is mixed. There's lymphocytes and histiocytes, but there's also a lot of neutrophils. There's necrotizing inflammation in a number of areas, and there's a lot of neutrophilic tubular inflammation with tubular destruction. The other thing that maybe you picked up on looking at this image is that the tubular epithelium has this very kind of reactive look, where these cells are very large, the nuclei are large, and they may not just be reactive. You begin to get the sense that perhaps these nuclei could contain viral inclusions. And the reason I say that is that in contrast to reactive nuclei, which often have nucleoli or granular chromatin, these instead have this very kind of uniform sort of ground glass, sort of grayish look. And this can be a look that you can see in viral cytopathic change. Here's another image, again, showing some of those nuclear changes that made us wonder whether we could be seeing evidence of viral infection here. And then there's this background, of course, of necrotizing interstitial and tubular inflammation. And indeed, we knew the clinical history of adenovirus infection, and so we performed an adenovirus immunohistochemical stain. And there's some non-specific staining here in the area of necrosis. That doesn't really matter. What matters is that we're seeing very clear specific staining within tubular epithelium, and it's specifically in areas where we're seeing those viral inclusions and in areas of dense inflammation. In the areas of kidney that were better preserved and less affected by inflammation, we did not see inclusions. So it seems to be a very specific staining pattern. And so we diagnosed this as adenovirus nephritis with necrotizing interstitial inflammation. I'll hand it back to Chloe to describe what happened next.
Great. So in tandem with getting this biopsy, we were able to send serum adenovirus studies that were notable for high viral load of 3 million copies and a 6.5 log. Also sent it in the urine with high viral load and log as expected. So then with regards to her subsequent course, she remained febrile for over 2 weeks, despite halting her immunosuppression, essentially continue only on prednisone. So high persistent fevers and rise in her LFTs, with a rise in her AST and ALT on hospital day 16. She continued to have anemia with a nadir of her crit to 18. And then she had persistently elevated serum adenovirus despite halting her immunosuppression with greater than 10 million copies or a log greater than 7. So overall off the charts. So then next we had discussed pursuing cidofovir therapy for this patient. However, her creatinine and her acute kidney injury overall made family and our overall team concerned about the risk of nephrotoxicity with starting cidofovir. So thus we pursued treatment with the Seraph 100 microbiome filter, which I'm going to discuss briefly in the next slides. And just want to acknowledge that this is a discussion of a use of a device that's not FDA approval for this indication at this time. So the Seraph 100 microbiome affinity blood filter is a single-use extracorporeal broad-spectrum sorbent hemoperfusion device, and it's designed to absorb pathogens when added to extracorporeal circuits. And how it works, it's immobilized polyethylene beads are bound with heparin. And overall, these beads mimic the chemical and electrostatic interactions of cellular heparin sulfate to bacteria and viruses. So overall, this is approved in the US by the FDA under EUA for severe COVID-19 infection, ARDS. And overall in the EU, it's approved as an adjunct treatment for pathogen removal. And these are just a couple of the publications that have highlighted use of this. You can see these are adults with COVID-19. You can see someone had used it with Epstein-Barr virus. And then the bottom right case report is actually from Cincinnati Children's use of this in a child with severe COVID-19 infection. So overall, we pursued IRB and company approval, and we're able, after a lot of work on our team, including especially Shina Menin's part, was did pursue initiation of the Seraph therapy for this patient. And this was connected with CRT using the Prismaflex. And you can see the HF1000 filter and then the larger Seraph filter. And overall, it has quite the large blood volume here. So it was total of 352 mLs of blood volume. The filter, the Seraph filter itself is 160 mLs. And we had initially planned for 24 hours of therapy here. And want to note that she was actually not requiring CRT for her kidney injury at this time, but due to this filter, this was initiated in tandem. And so she received 2 treatments lasting only 5 hours each. Day 1, the filter clotted after 5 hours and prevented return of the blood. Day 2, she had line malfunction and after 5 hours, and thus the therapy was discontinued. So overall, only 26 blood volumes were processed, or a total of 10 hours of therapy. However, you can see with the gray bars being treatment number 1 and then treatment number 2, that her AST and ALT decreased after therapy. And then you can see her fever curve also dramatically improved, with the blue being Tmax less than 38.3. And then her adenovirus load also significantly improved. And on the next slide, we have just the sequential values of her serum adenovirus levels. And you can see here, actually, day 3 after starting the Seraph therapy, we were able to restart tacrolimus with continued decline in her serum adenovirus load, starting azathioprine on day 7 and continued decline. And now her creatinine normalized at 0.8, and she's maintained on TAC, MMF, and PRED, and doing quite well about 6 months out from therapy. So overall, I believe that this adolescent kidney transplant with disseminated adenovirus infection tolerated this first-time treatment with the Seraph 100 filter and had no major clinical adverse events related to the absorber, and overall had resolution of her adenovirus infection with good clinical response. And overall, this would suggest that prospective clinical studies of this absorber for disseminated adenovirus infection and other non-SARS-CoV-2 and disseminated viral infections are warranted, with also careful considerations of the risks of using this filter, such as need for vascular access, especially in a patient that perhaps wasn't requiring it for other modalities of therapy, need for initiation of CRT, use of anticoagulation with the risk of pulmonary hemorrhage, for example, and those who have disseminated viral infections, and then the loss of circuit and the circuit and subsequent blood loss in that setting. Then also balancing with the risk and questionable efficacy of using nephrotoxic agents such as cidofovir in this case. And so if other folks have want to read more about the case, it was published recently in Peace Nephrology by members of our division here, including Rob and Shana. And we, I believe, have just a brief amount of time if anyone has any questions. Yeah.
I wonder whether anybody in the group has had experience using the Seraph microbiome column for COVID or for other infectious diseases. It was a new one on me for sure. Well, I think we showed them something new.
Yeah, and I think there's a lot of thought about how this implicates with our bone marrow transplant population, for example. And I know Shina had gotten a lot of communications from our bone marrow transplant team. So I think there's a lot more to come from this device and a lot of really exciting things on that horizon. And I can answer other stuff in the chat. So thanks, everyone.
Yeah, I see a couple of nice comments in the chat here. There is one specific question. a couple of nice compliments. Caroline Jackson says, thanks, groundbreaking in the peds world for sure. Megan Griffin is asking, is there a way to know which viruses this might be useful with? Your sound's
Yes.
off. Oh, there you go.
Yeah, yes, there is. There is actually, I can try to send it to you. There's a nice diagram with the filter that says kind of what viruses theoretically would be applicable for this. So I'm happy to send that your way.
Very cool. There's another question in the chat. Chris Blosser asks, why do you think she had such difficulty controlling the adenovirus?
I think her everolimus was a large factor at play. Perhaps in retrospect, we should have just discontinued it immediately, because overall it took quite a bit of time for her levels to come down. And I think that was perhaps a implicating factor here, but it's hard to say exactly why. She's done really well since, which has been encouraging.
Yeah, following this biopsy, I was following her chart and was really it was remarkable. She was in the ICU. She was very ill. She had this multi-organ involvement, and once the filter got utilized, it was really impressive how rapidly all of her laboratory results normalized and her clinical conditions improved. All right. If there aren't any further questions or comments, we will go on to the next case, which is presented by Dr. Sarah McHugh.
Hello, I'm Sarah. I'm one of the first-year fellows, and we will go over a perplexing GN case. And so for presentation, we have a 10-year-old with trisomy 21, obstructive sleep apnea, tetralogy of Fallot, who had repair, who presented with tea-colored urine in the setting of 1 month of really not feeling well with fatigue, weight loss, and being pale. He was initially admitted at Mary Bridge and then discharged with plans for close follow-up, and then readmitted to Seattle Children's. And so his main symptoms, he had impressive fatigue, and then these intermittent episodes of weakness. He'd be playful and then just suddenly turn pale and fall to the ground, kind of odd. He was seen a couple of times for these symptoms, and they had thought that, you know, they just chalked it up to potential URI symptoms and sent him home. Other symptoms that he had occasional epistaxis, chronic congestion, and some intermittent fevers and alopecia. He didn't have any chest pain or respiratory symptoms, no arthralgias or rashes. His other pertinent medical history, he has a right ventricle to PA conduit related to his tetralogy of Fallot repair, and he'd previously been on ECMO after a cardiac arrest from a tonsillectomy. For family history, there is a history of autoimmune conditions, lupus in his aunt, and then type 1 diabetes in some paternal relatives. And so his initial admission to Mary Bridge, he was admitted there for 3 days and underwent the following workup. And so here his electrolytes were relatively okay. His creatinine, though, you'll see is 0.98. His baseline is typically 0.3, so quite elevated. He also has an anemia that was hyperproliferative with a retic count, and he was also found to have iron deficiency as well. His inflammatory markers were elevated. His complements were normal. His ASO was slightly high, but group A strep antigen and culture were both negative. And then for serologies, he had an ANA that was mildly positive, and same with ANCA, and a mildly positive PR3, along with a positive rheumatoid factor. The other serologies listed below were negative. His urine, he had a mildly elevated urine protein creatinine ratio at 0.3, and then his urine showed many red blood cells. And they did get a renal ultrasound as well, which showed mildly enlarged kidneys with increased echogenicity going along with more of an acute process. And so he was given a unit of packed red blood cells for his anemia and improved symptomatically with improvement of his hemoglobin as well. His creatinine improved slightly, though not near baseline with hydration. And he was ultimately discharged home with plans to follow up with nephrology closely along with rheumatology for further workup. He was home for a few days, and then his symptoms returned, and he had worsening chills, fatigue, and anemia again, and then presented at Seattle Children's. And so just thinking, like, what information would you want to know and what is on the list of possible etiologies? You guys can type in the chat, and then we'll go over his labs and his exam at Seattle Children's. So his vitals were all relatively stable. For HENT, he had some dried blood in the right nares, indicating an episode of epistaxis. For cardiac, he had a grade 3 continuous systolic murmur. And otherwise, he really didn't have, like, the rest of his exam was pretty unremarkable. And he, didn't have any rashes or bleeding.
And there's a question in the chat. Did he have any recent respiratory or skin infections?
No. And so repeat labs, he had a worsening creatinine. His creatinine is now 1.5, up from 0.78 at discharge. And once again, his baseline was 0.3. Now he's developed concerns for a pancytopenia. He continues to have iron deficiency, though his TSAT has improved slightly, and his anemia continues to be hyperproliferative. His inflammatory markers are still increased, but slightly improved compared to prior. Complements are still normal. His anti-DNA did when given his high ASO, and that's still a little bit high. His ANA remains mildly positive, and now his ANCA and PR3 are more positive. His rheumatoid factor continues to be positive as well. An anti-GBM was sent that was negative, and then viral studies for EBV and CMV were negative. The repeat UA continued to show red blood cells, and his UPC is slightly worse at 0.68. And so we were concerned for an ANCA vasculitis, given the ANCA and PR3. And so we pursued some imaging studies to rule out pulmonary and sinus involvement, and those were all negative.
And there's a question in the chat whether there were blood cultures.
There were no blood cultures. And he was afebrile throughout his stay here. And then we had talked to Room, and we were still like wondering, is this a granulomatosis with polyangiitis or ANCA vasculitis? And so we decided to pursue a kidney biopsy, though we were kind of perplexed by his pancytopenia, given that that's not classic for an ANCA vasculitis, and given his history of trisomy 21. So in discussion with the hematology oncology team, that it would be prudent to rule out a malignancy with a bone marrow biopsy, and that was negative.
So this is an image, low power, of a trichrome stain of this kidney biopsy. And what I want you to see sort of at low magnification is that the general picture here is one of interstitial edema. There are no chronic interstitial changes. There's no fibrosis here. And there's also interstitial inflammation, which I'll show you more of in the next image. So at kind of moderate magnification, there's interstitial inflammation that's predominantly lymphocytes and plasma cells. There's interstitial edema, and there's some sort of reactive tubular epithelium here without extensive tubular injury. And we'll get back to what's going on in this glomerulus in a minute. We had a total of 27 gloms to look at, which is a little bit of a small sample by our standards, although I know that in adult world, that's still a pretty good sample. And most glomeruli looked like these here. They were enlarged, particularly for a 10-year-old. And they look kind of busy. And the reason that they're busy is that they've got sort of enlarged prominent endothelial cells and a lot of circulating leukocytes, mostly mononuclear leukocytes. However, a few glomeruli had more specific changes to them. So up to 1 per level had segmental sclerosis. I actually just discovered this last night when I was reviewing the slides. And rarely you could find glomeruli that had a little bit of this going on. So what's going on in this sort of quadrant of this glomerular tuft is that there's some glomerular basement membrane remodeling. You can see that there's a little bit of like remodeling, duplication, kind of complexity to the glomerular basement membrane contours. And there's a hint here of some endocapillary proliferation And this is about as good as it gets. And it was really only just 1 or 2 gloms per level that had these changes, and they're quite focal and quite segmental. Additionally, of the 27 glomeruli, we had up to 1 per level that had a cellular crescent, and additionally up to 1 per level with sort of a necrotizing and cellular crescentic process. So you can see a little bit of fibrinoid necrosis here. And in other levels, I think you could make out some glomerular a breakage of the glomerular basement membrane. So not extensive, but definitely some change, some things going on. Immunofluorescence was interesting in this case. This is an image of the IgG stain, which this is negative. This is background staining by our standards. IgA had some predominantly mesangial staining. So you can see this kind of arborizing immunofluorescence pattern with segmental capillary loop staining. You can see a bit of that here. IgM was brighter and was also mesangial with kind of more extensive capillary loop staining. C3 and IgM were co-dominantly bright. This is the C3. And the C3 you can see is again predominantly mesangial with a little bit of capillary loop. There was moderate C1q staining and also a little bit of C4 staining. So to summarize the immunofluorescence pattern, all of these had a staining pattern of mesangium and focal segmental capillary loop staining. C3 and IgM were 3+, C1q was 2+, and then IgA and C4 were fainter, but definitely still present. IgG negative. Electron microscopy kind of bore out the observations we saw by immunofluorescence, where we saw electron-dense deposition predominantly in the mesangium. So here's a mesangial area where you can see these electron-dense deposits often lying kind of under the glomerular basement membrane, but also some within the mesangial matrix. Here's some more here in mesangium and then kind of extending out mesangial waste. And this is a close-up of this area of mesangium, again, showing these electron-dense deposits. And then another image, again, showing predominantly mesangial deposition. And then every once in a while, we could see a little bit of typically subendothelial immune complex deposition out in capillary loops. I think there were a few that were intramembranous as well. So signed this out. I wasn't sure what was causing this, but it certainly didn't look like an ANCA vasculitis. It didn't look like a posse immune glomerulonephritis. So I signed this out as an immune complex glomerulonephritis with rare necrotizing and crescentic lesions, less than 10% of glomeruli. And I suggested that this looks like some variant of a membranoproliferative glomerulonephritis with immune complex deposition, but the etiology wasn't really clear. The features weren't those of an ANCA vasculitis, in the sense that we were seeing immune complex deposition, and in the sense that there wasn't extensive glomerular injury, there weren't extensive crescents and so forth. I'll bounce it back to Sarah to talk about what happened next.
All right, so yeah, as Robin said, the kidney biopsy showed more concerns for an immune complex glomerulonephritis, and given the degree of his rising creatinine and kidney involvement, we felt that it was less likely to be an ANCA vasculitis and that we would have seen more necrotic or crescentic glomeruli than what we did see. And so we're thinking, is it, what else could be going on and what further workup did we need to pursue?
I see a question in the chat. Do we have cryo? I'm guessing that means cryoglobulinemia.
Oh. Well, keep going. And so we actually did an echo, and interestingly, we had, initially thought about this as well before doing the kidney biopsy, but he had an echo within the month, like almost exactly a month, for routine tetralogy of flow screening that did not show any changes. But after these findings, we did another one, and that revealed endocarditis. And so we repeated his complement levels. His C4 was now decreased. We obtained blood cultures and started him on IV antibiotics. However, he continued to improve. His blood cultures, or did not improve, sorry, and his blood cultures had no growth. And so we had talked with other potential causes for culture negative endocarditis and ended up stemming some other studies. and his Bartonella titers came back markedly elevated. With further history, he had multiple contact with pet cats and dogs, though he didn't have any scratches or bites. And so we transitioned him to doxycycline and rifampin. And kind of a timeline for his whole course. So he had symptoms start early in the summer, had his routine echo, his admissions with repeat echo, and then was started on Bartonella treatment. And interestingly, in his outpatient follow-up, his CRP is improving, but his Bartonella titers are essentially the same, even though he's been on antibiotics for a while now. His renal insufficiency continues to be about the same as well. His creatinine is still 1.5. And his echo continues to still have vegetations, and now he has significant stenosis. And so it's pretty much a discussion with cardiology and infectious disease now about what will happen first. Like, will we continue antibiotic therapy and try to clear the infection and then have his right ventricle PA conduit replaced, or will he need surgery first? Right now, they're trying to just clear the infection, and he has pretty close follow-up with infectious disease, but we'll see where he's headed. His symptoms are still continuing, though on exams, outpatient, he seems to look pretty well. And so as far as Bartonella infective endocarditis and GN, it's an uncommon cause of culture-negative endocarditis, and there's about 54 reports of Bartonella endocarditis leading to a crescentic GN with PR3 ANCA positivity, and the kidney biopsy revealing an immune complex GN. One case, the patient also had pancytopenia. And so here over in this table from one of the case reports that reviewed all 54 as well, about 35 of them are ANCA positive and PR3 positive. And the thoughts to why that happens is Bartonella essentially involves diffuse endothelial cells and inhibits apoptosis. And so it's thought that with the inhibition of apoptosis and involving vessels, that allows PR3 to remain in contact with our host immune system for a more prolonged period of time, allowing for production of anti-PR3 antibodies.
Huh. I thought it was really interesting when you found this result. I had not heard of Bartonella or any endocarditis causing a positive ANCA positive PR3 before. There's a couple of questions in the chat. One of them is, does he still have pets?
I think so. He's actually followed by the nephrologist down in Marybridge, Dr. Dokras. So.
Yeah. And then the other question was his Bartonella titer predominantly IgM to match the immunofluorescence findings, which you remember were IgM dominant without any IgG?
Yeah, that's actually a good question. Let me look.
Yeah, I remember looking at his titer results, and I can't remember. I want to say his IgG and IgM were elevated, but I can't remember. Are you looking?
Yeah.
Yeah.
His IgG was his IgM is actually not elevated. It's mainly his IgG.
Oh, so his IgG is elevated, but his IgM is not?
Yep.
Wow. Okay, so that's different, huh? And then Dr. Alpers asks, following Kelly's question, what will you do about the IgA? So going back and looking. So IgA was what was present here. It was not the brightest component. Are you asking, Dr. Alpers, whether there's also concurrent IgA deposition independent of the endocarditis driven MPGN? Is that what that means?
That is part of it, could be, but also, is there an underlying IgA that's been there all the time?
Right.
With what we're increasingly knowing about IgA, assuming you get this patient well past this acute episode of systemic disease and kidney disease, what do you do about that? I mean, he has a lifetime risk for CKD. As a result of that, do you start treatment in some shape or form for IgA at this point in time? I guess it's a general pediatric and then becoming adult nephrology question.
I think the first step, it seems to me, would be to establish that there are possibly two separate pathogenic processes going on, and that the IgA isn't secondary to the Bartonella. And in order to do that, it seems to me that you would need to document that the IgA persists after the rest of it has resolved. Is there another way to do it, do you think?
I don't know another way,
Yeah.
but I'm increasingly aware that these things maybe are something that shouldn't be ignored, particularly in a young person whose lifetime risk for CKD from that is obviously can be large, depending on what kind of studies you read.
Yeah, well, and my worry would be that his risk for CKD could be elevated anyway, because he's now had this glomerulonephritis. So it seems, and particularly since he continues to have elevated renal dysfunction, which we've got on the slide here. Yeah, since he continues to have renal insufficiency, my worry would be that there may have been some more longstanding injury or ongoing injury. So I wonder whether he may be headed for a repeat biopsy at some point in his clinical course, and that'll give us a better handle on it. But it's good to bear in mind, I think, that you're right, that there, in addition to this episode of glomerulonephritis, there could also be a smoldering background IgA. Any further questions on this case or comments? All right, we will move on to our final case with my co-presenter, Dr. Amber Kazi.
Cool. Hello. Mine may not have as interesting of an introduction, but the kid I'm here to talk about, AB, so he's 15 years old. He has a history of asthma, and he actually came to our clinic because of proteinuria and hematuria. So he actually been doing really well. He just had, cold symptoms that had been improving and really hadn't had any history of renal insufficiency or anything that would point to like GM, no rashes, no joint pain, swelling. And really the reason why the family brought him was because they had seen his pediatrician in June because they had a known family history of familial lecithin cholesterol acyltransferase deficiency. And he had tested positive for hematuria and proteinuria at his family clinic. So the two siblings that he had, older siblings, were both known to have this. So both his older brother, who's 29, was actually diagnosed in 2011. He had originally presented with high triglycerides, normal cholesterol, and then had proteinuria and actually had eye disease as well. He hadn't had genetic testing, but he did have a biopsy. And then his older sister, who's 32, who doesn't have as much information in her chart because it was from a long time ago, but also I know was diagnosed with kidney biopsy after also presenting with hematuria and proteinuria.
Yeah, and that was also done at Seattle Children's just back in 2008.
Yeah. So for him, so his labs, so he had labs done at his pediatrician's, and overall his kidney function and lights all looked pretty good. Really what's kind of outstanding on this is his lipid panel. His triglycerides are very high. His HDL is low, and he couldn't calculate his LDL because of the triglycerides. His urine microscopy during his clinic visit showed blood and protein. And Dr. Okamura, who saw him, had written that he had RBCs 75 to 100. He had a mixture of different casts, including red cell cast and mixed cellular cast, and his UPC was elevated to 6.6. So because of the family history and his urinary findings, it was decided that he needed genetic testing, and then he went for biopsy in August.
Yeah, so here's how his kidney looked at biopsy. Generally, we've got well-preserved cortex with some patchy areas of interstitial fibrosis. I'm showing some of those here. Overall involving about 20% of the cortex. And at this magnification, most of the glomeruli looked pretty okay. Looking more closely, there were some segmental and focal abnormalities of the glomeruli. So you could find glomeruli that had areas of segmental mesangiolisis, and I'm showing some of that here. And you could also find glomeruli that had segmental areas of mesangial proliferation. When you read about familial LCAT deficiency, one of the things that you see described sometimes is aggregates of foam cells in either the interstitium or in capillaries or occasionally in glomeruli. I did not see that in this case. However, when you go and you look at the glomerular basement membranes very closely, and the Jones stain shows this best, what you do begin to see is areas like this, and here. And once your eyes are on, they kind of pop out all over. So there's these very characteristic kind of punched out looking bubbly lucencies in the glomerular basement membranes in many of the glomeruli. Here's another image. It's showing another glomerulus with similar findings, where again, it's these very kind of discrete areas of lucency within glomerular basement membranes. And then when you look at trichrome, you can make out these sort of very fine deposits along capillary loops staining red by trichrome. Lots of things stain red on trichrome. One thing that can, though, is immune complex deposits. So it's important to note that in family LCAT deficiency, you can have light microscopic findings that are mimics of membranous nephropathy. And in fact, I think one of his siblings, when they were, the first one, the sister, when she was initially biopsied, the initial diagnosis was membranous nephropathy. However, the immunofluorescence pattern in this is quite different from a typical membranous nephropathy, although I suppose you could speculate that it could be like one of the advanced stage ones where you've had sort of washout of the immune complexes. At any rate, his immunofluorescence was entirely negative for IgG and IgA. The IgM had this variable, sometimes segmental staining. So I'm showing 3 representative glomeruli to show the spectrum of findings that you saw, where many were negative. A few had sort of segmental staining in capillary loops, and then rarely you found ones with more extensive global staining. C3 had similar findings where there was a spectrum of staining ranging from just very segmental, kind of around the hilum, to more extensive staining of the whole capillary tuft. And C1q, rare glomeruli with segmental staining, and C4 also had some segmental staining in a subset of glomeruli. So not really a typical picture for membranous nephropathy, kind of a variable spectrum of staining, mostly of complement proteins. The electron microscopy for this case was very distinctive, and I'm going to show you that in the next couple of slides. So within the glomerular basement membrane, you can see numerous well-circumscribed areas of kind of varying electron lucency and electron density. Some were very electron dense with this kind of halo around them. And then in others, it was like the electron dense material was absent and you had just that punched out halo. And there's glomerular basement membrane reaction to these deposits, where you can see that the basement membrane has grown up around them and is surrounding them. And it's a nice correlate to what we saw by light microscopy with those sort of punched out bubbly areas of lucency. Here's a close-up image showing what some of these deposits look like. Again, you see variable electron dense and electron lucent material. The literature describes this as sometimes having kind of a striated appearance. I didn't really see that in this case. And then in some areas, the degree of basement membrane remodeling is substantially more. So here you see quite a lot of deposition with basement membrane material kind of around these deposits. And this is just another image showing an area where they were quite extensive in deposition. And you can kind of see how you might even, in addition to those punched out lucencies, by light microscopy, you might even see subepithelial spikes. One article that I read about this described that sometimes you see this pattern of deposition fairly early on in LCAT deficiency, and then later on, you're more likely to see intramembranous and subendothelial deposition. I don't know if that's the case or not, but this is what we saw in this patient who was 15 at the time of biopsy. Thanks to the excellent Dr. Laura Finn, my predecessor, we did have images from both his brother's biopsy in 2011, which showed similar basement membrane changes, and his sister biopsied in 2008, who also had similar changes in her glomerular basement membrane. And we even had some EM images from her, which show similar, although I think less easily discernible, sort of punched out lucent areas within the glomerular basement membrane. And there's a couple of, representative images showing them here and here and here. So my final diagnosis here was glomerular basement membrane changes suggestive of lecithin cholesterol acyltransferase deficiency. And I commented in my report that the appearance was very similar in the siblings, And in all three changes, we saw those characteristic membranous nephropathy like basement membrane changes and the characteristic EM changes. It was very gratifying to look in the chart and discover that the genetic testing did happen and did in fact identify homozygous likely pathogenic variants in the LCAT gene in this patient. Both of them were the same homozygous pathogenic variant. And I'll hand it back to Amber.
All right, so how are they all doing? So our patient, he was just started on losartan due to high blood pressures and the proteinuria. As Robin alluded to, the genetic testing was completed. And so far, talking to Dr. Okamura, they're going to refer him to our lipid clinic to help with management of his cholesterol abnormalities. The middle kiddo, there's a care everywhere, and it looks like he's pretty much approaching end stage at this point. He's been referred to transplant and then has been struggling with our typical things that we struggle with end stage patients. But he does continue on lisinopril, and then he's on fenofibrate and rosuvastatin for his cholesterol issues. And the oldest kiddo actually has not been following with nephrology at all per her chart, but it's because her creatinine has been fine and she's remained on lisinopril, it looks like, for her proteinuria too. So just a brief, what is basically this LCAT deficiency? So at least with the familial type, it's an autosomal recessive disease, and there are at least 90, if not more, mutations that have been noted on the LCAT gene. There's also acquired deficiency that is possible. The clinical features are corneal opacities, anemia, and proteinuria, but it seems like the severity and the phenotype depend on the type of mutation. So other things you can see are hepatomegaly, splenomegaly, lymphadenopathy, and atherosclerosis. And the labs, they basically portend, which we'll show on the next slide, but we'll pretend to what's happening with this deficiency, but you end up having elevated cholesterol, low HDL, low LDL, low apolipoproteins A1 and B, and elevated triglycerides. You can see a hemolytic anemia with this as well. And then, like we discussed, you can have elevated protein in your urine and hematuria as well. So this slide we're going to try to manage together, Robin. But so in this whole picture, so that LCAT is boxed there. It's a protein that's associated with lipoproteins, and normally it's bound to HDL. Its role is to esterify cholesterol, and so it basically helps make those spherical HDLs you see next and prevents removal of the non-spherical HDL through the kidney, and basically helps prevent the backup of cholesterol to peripheral cells. So basically what happens is once this is all said and done, these will move to the liver. So when there's a deficiency, you don't have any more of this spherical HDL, and you actually get this lipoprotein X molecule that's made as well, which is thought to be correlative to kidney disease. But as you can see, since there's no more spherical HDL, you actually have low LDL because you don't have movement to that anymore. And you end up having increased free cholesterol and increased triglycerides as well. So that is the thought process of how that works. Right now, there really isn't treatment besides supportive measures to get through the kidney disease as well as the cholesterol management. If you look in the literature, there are things coming out of Europe looking at replacement of the enzyme, gene therapy, and LCAT activators, but at least nothing that I saw is being used here. And the major morbidity and mortality actually comes from the renal involvement. So it tends to start in the second or third decade of life, and the end stage tends to progress in the fourth or fifth decade. And then because we're not really treating what's causing the kidney disease, recurrence can happen in transplant as well.
So I had a question about that. Maybe you can answer this, Amber. I was reading that you can see histologic evidence of recurrence in the transplanted kidney, where you can begin to see lipid deposition in kind of the same pattern, but that clinically people sometimes continue to have good renal function. Is that what you read, or do they develop failure in the transplanted kidney as well?
That's a good question. I didn't read up further, like whether there's failure that continues. If I was going to take a guess at it, since it seems like it takes 20 to 30 years for this to like show itself, I'm assuming that the transplanted kidney probably can last some time with this disease, and it probably is more just failure of the actual kidney versus the disease that would cause you to go into renal failure. But that would be entirely stipulation based on what I was reading about the actual disease.
Yeah, and I didn't go into a lot of depth on this either. I looked at a couple of papers that sort of referred to it, but didn't go into the primary literature. So it would be nice if transplanting his brother's kidney is going to be sufficient to give him good renal function for a couple more decades.
That would be the goal, hopefully.
Yeah. All right. Are there questions or comments on this case? Look at that, it's 9:27 and we got through all three cases in good style. All right. Thank you, everybody. And we hope you have a great holiday, great new year, and we will be back in March with 3 more awesome cases. We appreciate everybody's attention. Thank you.
And thank you so much for 3 great cases and good discussion. And we will be back in January. So we're off the next 2 weeks, and we'll see everyone in 2024 for Nephrology Grand Rounds. Take care.